colleagues. I am Dr. Ridwanullah, one of the radiation oncologists from King Faisal Hospital, and welcome to this special SARO rounds. And we have a very special international guest today. It's my absolute privilege to introduce Professor Vedant Murthy, radiation oncologist from Tata Memorial Center in Mumbai. Dr. Murthy is a globally recognized expert in urological malignancies. He's been a PI, principal investigator of many landmark trials, which are practice changing. And for example, to mention a few, POP RT trial, PRIME trial, and now recently the BART trial we presented in the ASTRO meeting last year. So the BART trial is looking at the role of adjuvant radiation in high-risk muscle-invasive bladder cancer after neoadjuvant chemo and cystectomy. Thank you very much for joining us, Dr. Murthy. Kindly take over. Mike is yours.
Thank you so much, Dr. Rizwanullah. Absolute pleasure. All my friends in Saudi Arabia. I haven't visited, but I'm sure someday I will. But till then, it's good to meet you this way. I'm sure we have a lot in common, and I think I hope this is the beginning of a much deeper relationship between our very large and important institutions in our country. So it's a pleasure to be here. I can understand that all of you would not be treating urological cancers. Many of you, some of you would be trainees, some of you would not be aware of what this. So I hope I'll be able to give something to everyone today and be happy to take questions. As I said, I think there will be four types of people in this audience. Those who have never treated post-op bladder, largely because they don't believe it helps, and I think a lot of them would be surgeons. Certainly, they may not be in this audience, but that is true around the world. There would be some who believe that there's something there, but haven't started that and want to. There may also be maybe some people who have treated a few patients and need convincing themselves and the urologist that it really works and it is safe. And then there might be some or not who want to refine the technique and process. I hope there's a little bit of something for all these groups. So what I will cover today is why bother with adjuvant radiotherapy? What is the rationale? Why are we talking about it? Who are the patients who are likely to benefit most with radiation, which means who are likely to fail in the pelvis after surgery? And I'll talk about the trial itself and basically to see if it's safe, effective, and where are we heading next. When you suggest post cystectomy radiation to surgeons, most of them will say, "Oh my God, this is too bad, too much. We have done such a great job. It's a clean cystectomy bed, clean pelvis. That looks too dangerous." But surprisingly or not, a lot of radonks will also think the same. They will think, look at all the bowel there, and they say, "Oh my God, this is too dangerous. I'm not doing this." I was also one of these some years back, but then took some steps, and hopefully there will be enough here to convince many of you that it is not as dangerous as it looks. So, for those who don't know, advanced bladder cancer is treated with surgery, which is a cystectomy, and patients get a bag that is lifelong on their abdomen, the urostomy bag. We also add neoadjuvant or adjuvant chemotherapy that adds overall survival by about 5 to 8% using cisplatin. Much more recently, there is a lot of excitement of adding nivolumab or for adjuvantly or other immunotherapies. The field is very rapidly moving right now with, you must have heard of things like EV plus Pembro and Durvalumab, etc. So there's a lot of immunotherapy coming into the space. That also adds somewhat to the survival, and then we follow up these patients till either they are cured or they succumb to their disease. Now, if you look at the best data, including with nivolumab, you see here at 36 months, even if we do everything in our capacity, 40%, 35-40% of the patients will die of their disease or of other causes. So that is not a pretty scene. That is not a good place to be. It is a bad disease, and we must do everything in our power to improve that. One thing that has been underappreciated for a very long time is that although most people believe, and so do I, that a majority of failures after cystectomy are distant, it's a systemic disease, advanced bladder cancer. Many will get distant mets. Locoregional recurrences have been underappreciated. And work on this began about almost 10 years back. A number of studies, well, a handful actually, 5, 6, 7 studies, including our own data, you can see on the bottom right, have come up with something very interesting. Long story short, there are some patients who can be called high risk of a locoregional relapse after cystectomy. Those who have higher T stage, T3, T4 after surgery, those who have node positive disease, lymphovascular invasion, margin positive status. So these are the patients who are likely to have almost 25% locoregional relapse rates. And remember this 25 to 30% because I will remind this to you later in the talk. If you don't do anything, that's the number of people who will get a relapse. And when the locoregional recurrences happen, it can be very bad. These are not AI generated pictures. They are pictures of real patients having real relapses in the pelvis. And we've added this picture in the BART manuscript also. I think it's in the supplement. And when this happens, cure is impossible. Even palliation becomes very difficult. Unfortunately, what we know is chemotherapy doesn't seem to make a difference whether they have a locoregional relapse or not. This is data from an MRC trial, and they gave chemo and not chemo. This is not immunotherapy, remember, and you can see here there's really no difference. Chemo doesn't seem to make a difference, and remember this because I'll show this to you later as well. One of the big questions has always been, can we really treat the cystectomy bed safely? When it was 3D CRT, we couldn't. But as with everything in our field, IMRT has changed everything. It has allowed us to do things we could not have imagined 15, 20 years back when IMRT was not there. And here's a little bit of, well, actually, I'm going to skip this because, yeah. So, it's all very well to say that you look, IMRT, we should do IMRT, but what do you contour? There was no guideline. Nobody knew what to include in the contouring. So some people got together, led by colleagues from UPenn. They included me also at that time. In 2016, we published these guidelines. And this was mainly based on data from the pen. And it essentially said that if the margins are negative, you treat the nodes. And if the margins are positive, you treat the nodes and the cystectomy bed. At that time, this was the data, and I thought this was a little odd. There is no situation in radiation oncology post-op where you don't treat the post-op bed. I mean, that is very odd. So I was not sure that this really is true. we should treat the bed because and then we saw and others saw and we also published that in spite of treating only the pelvis, according to the recommended guidelines, 25% patients had locoregional failures outside the recommended consensus. And based on the further data after the guidelines came in, it was updated uh, to include the cystectomy bed in all the patients, including in R0 resection. It was also suggested to include the common iliac lymph nodes which were originally not treated, and these the most recent guidelines, most recent consensus says treat the bed, treat the pelvis, include the common iliac region. So that is the long and short of it. This is how the cystectomy bed looks like. You can see bowel there, and it's very easy to get a little worried about it. What is going to happen? How is the patient going to manage? But believe me, this is how it looks, and this is how all the patients we have treated. And I will show you the side effects. It is not as bad as it looks. The pelvic contouring looks like this, pretty much standard, 7 mm around the vessels. Then you grow a PTV around that. You may or may not use image guidance, but this is what the contouring guidelines look like. I'll show you some more planning, but very simple. IMRT using CBCT or megavoltage CT, we spare the stoma, we spare the bowel bag, and some constraints here. The evidence for adjuvant radiotherapy comes from 3 trials, the BART being the largest. Dr. Zaghloul from Egypt has been doing this work for the last 20-30 years. It's his brainchild. He's been the pioneer of this. Well, the fact is most of the Egyptian data was on squamous cell cancer, so it was not really relevant in TCCs. More recently, there was a publication of about 122 patients using very similar criteria. There's also data from France, which has been recently published. Outcomes are not there. Again, very similar. And we've got together and we are actually now working on a individual patient data meta-analysis called MERCY to pull all these 3 trials, randomized trials, to see if we can get better information about the outcome. So that is the background. With that background, we started this trial in 2016, so it was a long time back, and this was published a couple of months back in the JCO, and that is the reason I am talking to all of you this evening. What is this trial? It is a randomized trial. It was done in 4 centers in India. All the patients were high-risk muscle-invasive bladder cancer and had cystectomy and some form of chemotherapy. They had all these high-risk features that I have listed here. All of them were bad disease. They were randomized to the standard arm, which is actually observation, or the test arm, which is adjuvant radiation, 50.4 gray in 28 fractions to the pelvic lymph node and cystectomy bed. So thankfully, I had the foresight of including the cystectomy bed. And the primary endpoint is 2 years locoregional failure-free survival, and the total sample size is 153. I already showed this. This is how we contoured the bed and the pelvis. We used stoma sparing IMRT. You can see a little bit of contrast in the ileal conduit here. I don't know if you can see the arrow. We put a little Foley's, put some stoma. We can spare all that reasonably well. It's pretty simple IMRT. You can see here on the right the 50% isodose in light blue also very well spares the bowel in the lower abdomen and upper pelvis. Now these are the results. A large majority of patients have a T3, T4, 77% clinically. 33%, exactly a third, were node positive. Very importantly, 90% of the patients got chemotherapy. So this is the best that we can do today. Younger age. This is much younger than what is found in the West. I'm not sure the average age of a locally advanced bladder cancer in Saudi Arabia, but I think it would be very similar, about 60 years. Our surgeons dissected a lot of nodes, very few were margin positive. This talks about the quality of surgery, and very few had neobladders. That is not what happens in locally advanced bladder cancer. Of the 250 odd patients who were screened, 153 were randomized, 77 to the radiotherapy arm, and 76 to the observation arm. The analysis was done by intention to treat for the primary endpoint. This is the big finding. The primary endpoint of 2-year LRFS after a median follow up of 47 months was significantly higher, both statistically and clinically meaningful, 76 versus 87%. So you can see 11% improvement in by intention to treat. We looked at subgroups, patients who are likely to benefit with for locoregional relapse, and some interesting things came out. You can see here node positive patients were particularly benefited. Now, one would instinctively say, oh, if it's node positive, it's all going to relapse distally, don't bother locally. No, they had particular benefit in locoregional control. This is all in spite of chemotherapy. You can see here patients who were downstaged benefited a lot after chemotherapy. You would think that those who had a lot of response after chemo would not benefit, but that's not the case. Multiple risk factors, T3 and N1, still benefited. And those who received neoadjuvant chemotherapy particularly benefited after so in spite of this chemo, the benefit was there with radiation. So you can see here, instinctively you would say that these patients wouldn't benefit, but still these are the ones that actually got a benefit. These were the secondary endpoints. All of them had improvement in the range of 12 to 15% with adjuvant radiation. Unfortunately, the overall survival, although 12% improvement in overall survival at 2 years, it just did not reach statistical significance. Maybe we fell short of the sample size by maybe even 10 patients, but that is what maybe the meta-analysis that we do will have enough power to show an overall survival benefit. A lot of practice today changes because of the OS, but I don't think that is the most important thing. I think reducing locoregional relapses is also a very, very good endpoint post cystectomy. Some interesting things came out when we looked at the patterns of failure. In the observation arm, you can see here, and on the right there is the radiotherapy arm. When we gave the radiation, there was not a single patient who got an isolated locoregional relapse. This is the cystectomy bed, 2%, but this was in context of regional and distal. Whereas here you can see here locoregional without distant was in all these patients. So all this was avoided with radiation. Now, when we did not do anything, when we observed, look at the locoregional relapse. This is what we had predicted, and this is exactly what I told you. In high-risk patients, if you don't do anything, I was happy to see this. Our prediction was reasonably good. Locoregional relapse was about quarter of the patients. Very interestingly, in spite of all the chemotherapy, both groups had 30% distant metastasis. Now, clearly, chemotherapy can only do so much. That is why I think immunotherapy is also needed in these patients. Whether they can afford it, whether that is available, whether whether they can tolerate it is a completely different matter. We published our results of the side effects, which are most important, last year in the Red Journal. The severe side effects of GI. Now, this is what we were worried about. We thought everybody is going to get diarrhea and they are going to just fall apart. No, hardly anything. Really, there's no severe GI problems with 50 gray. 17% had grade 2 GI, which all of you would agree is a little bit of little bowel motion, loose motion, little bit of abdominal cramps, pain, only less than 20%. A cost well worth paying for the benefit. The late side effects were about higher with radiation, about 7%, 6-7% higher with radiation, and these included things like obstruction, ureteric obstruction, and other things related to kidney, but not a very big difference. The strength of this trial is that it is the largest RCT, multicentric. Everything was standard of care in the standard arm. One can't say that the standard arm was less than standard. Best surgery, best chemo was given, best radiation was given in the test arm. The weakness is that there is no immunotherapy. I think it's not a weakness, I think it's a strength because it shows that when there is no chemotherapy, immunotherapy, radiation really has a role, especially because many people around the world cannot afford immunotherapy or cannot tolerate it. As I said, we probably fell short on the sample size a little bit, but that's not a big deal. I think still the benefit is quite large. Now, what are the threats? I think the threats are real. The fear of adjuvant radiotherapy among the surgeons and among the radiation oncologists, and I think this trial will do it'll help in allaying these fears that look, it is safe. But the biggest threat is the rapid adoption of new adjuvant immunotherapy. I think there's a lot of uncertainty in that area. We don't know how the responses are there. There's a lot of patients who are getting complete responses now. So, whether adjuvant treatment should be given, what is the role of adjuvant radiotherapy in that area, is becoming more and more difficult uh, to pinpoint. But I'm most excited about the opportunities. Radiotherapy and immunotherapy have to be combined. They have non overlapping side effects and they have non overlapping effects. So, I don't think chemo certainly doesn't help locoregional control. I don't think immunotherapy would either. So, radiation would do the locoregional, immunotherapy would do the distant. And I'm also excited about the meta analysis that I told you we are doing with the other trials. So my takeaways for you is there is a significant locoregional relapse with high risk cases after cystectomy, and this happens in spite of all the chemo that you give. There are 3 RCTs have shown that it is safe, and I think it is reasonable to start doing this thing. Now there is evidence. You must speak to the urologist, say that look, this is a problem. Immunotherapy is not always there, it cannot always be given, and radiation is a cheap and safe option for these patients. IMRT contouring guidelines have not gone into great detail, but look it up if you want to do the practice. Contour a few patients. Let me know if you need any help with any contouring. Any of you happy to connect with me. And I think reducing the locoregional relapses itself is a worthy goal. But I'm sure when we do the meta-analysis, even the overall survival, at least I hope, will come as positive, as significant. This is my team, my colleagues who have helped doing this trial. As I say, we are raising the BART in bladder cancer treatment. But most importantly, my fellows and coordinators and residents who've worked very hard, and so that I can enjoy all the fruits and talk to all of you on this stage. Thank you so much. Thank you so much. Happy to take any questions.
Thank you, Professor Murthy, for this excellent talk, very comprehensive presentation of your BART trial data. Congratulations for successfully completing this trial. Let me start off the questions. I liked your first slide a lot because initially I was really afraid of doing any sort of adjuvant radiation. And then I had no choice with a patient with positive margin present in the tumor board. And I reluctantly started doing the adjuvant radiation. And the first patient, when I finished according to the contouring guidelines, it was just a bunch of bowel in the pelvis. And I was wondering what I'm doing, just irradiating all this bowel. uh, so it was nerve wracking, the first case, and I was like watching the patient very carefully, every week in the review clinics, and I was just pleasantly surprised
That's it.
how they they tolerated this 50 grade to the whole pelvis with the IMRT techniques. It was like an eye opener for me. Initially, I was dreading to do it,
Yeah,
but
yeah,
the patient managed it extremely well. Uh, so slowly, that's the time when I just started, and some note positives came, and I was offering to our urology colleagues. So it's just as you mentioned, the EV Pembro data. So this is what I think FDA has approved EV Pembro for cisplatin
neoadjuvant.
ineligible and cisplatin eligible last week or something. So that's going to kind of change the practice a lot. And when looking at the trial outcomes, this pathological complete response, which you mentioned, is about 50%.
Yeah.
So that is a kind of a big number compared to the neoadjuvant chemo, what we used to see. And I was wondering whether this will how it's going to affect the kind of indications for adjuvant radiation when you're having such a good response. Uh,
Yeah.
thank
Yeah.
you.
Yeah. So that is one question that I don't have an answer to. I'm glad you started using it, but you see, let me ask you, and all of you, there are a few hands that are raised, but let me ask you, Dr. Rizwan, in Saudi Arabia, for the common Saudi, how often can they afford adjuvant immunotherapy? Is that standard for everybody?
So I can only speak for my institution. In King Faisal Hospital, there is good funding for immunotherapy drugs, and I see them in practice. All the patients having, at the moment, the metastatic patients, I can see they're having EV Pembro, and once it's gone to the committee, I'm sure they'll be able to use it for neoadjuvant as well.
Okay, what about adjuvant? So immunotherapy is quite big in King Faisal. So that you're very lucky. Your patients are lucky. So I think I think that's a very good thing. But the fact is, a lot of people can't. A lot of people, even in India, it's out of pocket. If you can't afford it, you don't get it. One can try lower dose of nivolumab. We can try other things. EV is still not available. It's exorbitantly expensive. So I think uh, this fits in very well. And if you are using adjuvant nivo or EV, I think you are in a great position. You have reasonable amount of bladder cancers. It's reasonably common. You are using EV and you are enthusiastic radiation oncologist. I think you have a very good opportunity to combine both, either in a trial, small pilot study, and I'll be happy to discuss this further. Because those who have EV Pembro don't believe in the radiotherapy. Those who have radiotherapy don't have the immunotherapy. So you are in a great position that when we can talk about it in the future. There are some
Sure.
questions.
Thank you. Yeah, let's take the questions from the audience.
I think you can start with Dr. Al-Khamis. He has his hand up.
Assalamu alaikum. Good afternoon. Prof. Morty, it's a pleasure to have you with us. It's really an eye-opening talk. I'm Mohammed Al-Khamis, your oncology consultant. You shared in your slides some patients who had neobladder prior to the adjuvant immunotherapy. We know ideally for patients who have locally advanced disease, You should not get a neobladder unless it's technically feasible and the tumor is far away from any vital structures. But we do come across certain cases where the pre-op staging shows no lymph nodes and lymph nodes post-op are positive, and the patient undergoes a neobladder. Would that be a problem for you in radiating a pelvis that has a neobladder, not only bowel?
We had about three patients in the trial, so they were irradiated, and we modify our fields suitably to avoid or reduce the dose to the neobladder. There is also data from US from Leslie Wallace. There's small series that have treated patients with a neobladder, and I think having been doing this for 10 years, I think with modified fields we can safely treat even if there is a neobladder. And I take your point, there will certainly be patients who will have a neobladder and an indication for adjuvant treatment. It can be
Perfect.
done, it will need a little bit more experience, it will need a little bit more care, but I don't see why that should be a problem.
And timing-wise, if you are going to give it
Yes,
post-operatively.
yes. So now you mean how to time it with the immuno?
No, I mean, when do you start giving the immunotherapy?
So the
Because the neobladder takes some time to heal, correct?
uh, so the question is, when do you start the radiation?
Yes.
In the trial, we allowed up to 8 weeks to start the radiation after cystectomy.
Perfect. It's very clear. Thank you very much.
Yes, you see these patients, they've had a lot of neoadjuvant chemo, they've had a big operation, they've got a bag, they are really fed up, they have had a long time in the hospital running around, big difficult treatments, neoadjuvant chemo is difficult, cystectomy is difficult, and then to tell them that, look, we want to take you in a trial was very difficult for me to pull off, because many just wanted to go home. So to convince them, look, this may benefit you, was tough. So we allowed about 8 weeks, and many of them recovered within that, and we were able to treat them.
Much appreciated. Thanks, Prof. Murthy.
Thank you, Professor. Was there a package time? Where did you, from surgery until you complete the radiation, was there effect of a package time like what we have in head and neck where you do adjuvant?
Not really. I don't think that was there. I mean, whether we will be able to do it itself was a question first. So I don't think we could make it so tight that we had to finish in a certain time. There was no evidence that doing it early helps. Finally, this a lot of them got adjuvant chemo as well. Some at least 20% got adjuvant chemo as well. So we didn't have such a overall treatment time.
And there is also a question in the chat box from Dr. Royce. He said, do you think post-op adjuvant is the ideal time for RT?
What do you mean, Dr.
Dr.
Alvarez?
Royce, yes. Dr. Royce, if you can elaborate on your question.
So does it mean that post-op instead of pre-op? I'm not
Yes,
sure.
I was alluding to, for example, any advantage of giving it in the neoadjuvant, sort as what we do in the, rectal cancer to
Yeah.
shorten the treatment time.
Yeah. Very interesting question. I don't know. In the 90s, there were several randomized, at least a few randomized trials that studied neoadjuvant radiation in bladder. But with the 90s technology and how things were done, I don't think it was a success. I am very interested in studying neoadjuvant radiotherapy in locally advanced bladder cancer, but I think the way immunotherapy has come in, none of us stand a chance of any of this. So if we can establish adjuvant treatment, I think that itself would be a big achievement. What I think all of you have a great opportunity in doing is combining IO with RT. I think that is the space that everybody is looking for, and if you can pull that off, if you have the patients, if you have the drugs, and that would be a great space to do it.
And Dr. Murthy, from your experience in so population-wise, Saudi Arabia and India is similar. I've been lucky to visit India multiple times, and I see that I can draw some parallels when it comes to offering an experimental treatment. This is a big challenge here in Saudi Arabia. No one wants to be in the experimental arm. It's completely opposite to when I was in the US and Canada, where people want to try the new treatment. So, how did you overcome this anxiety from, introducing a new experimental treatment, and how do you address this? Because we're trying to get more people on clinical trials, and I think your perspective is much appreciated on this matter.
Some treatments, patients love. Now, I will give you an example of prostate trial. We have just completed 550 odd patients in a randomized trial in prostate cancer. We have compared 5 weeks of radiation to SBRT, which is 5 days. Now, when we were accruing to that trial called Prime, I was having such a great difficulty in telling patients that, look, if you're not on the trial, we can't give you SBRT. Everybody wanted 5 days. They said, we don't care if there is more side effects, just give us the 5 days because it's so much more convenient. So here it was completely different. These patients were weak, frail, and fed up. It is how you talk to them. I think that comes over time. If frankly speaking, at least when I tell the patients that this is not a good disease, there is a chance that it's going to come back, and we are trying to do something to prevent it from coming back, I think that is what clicks the most with these patients. So then they said, okay, it is so you'll have to make them understand that, look, there is still a problem. You had the treatment, but it is not enough in our view, which is true. It is not wrong. So the phrasing becomes very important.
I agree, and having recurrent bladder cancer is not a walk in the park. It's very challenging, and by that time, patients will be more frail to get more intense systemic treatments, which is something being in pediatrics, I know that if you hit the cancer really hard at the beginning, especially worms and whatnot, it's better for the patient than them having a relapse and then nothing you can offer to them, or they would end up taking a more intense chemotherapy, going into more neutropenias. So I think sharing that perspective with patients is important.
One very important statistic came from the trial. It's in the paper. If you got a distant metastasis, the median time to death was 7 months, and if you got a loco-regional relapse, the median time to death was 7 months. So if you even get a loco-regional relapse, it takes the same time for the patient to succumb. So it may appear that distant metastasis is, in spite of all the things that we do afterwards, it's as bad, and it's more painful.
Absolutely, absolutely.
So, is there any more hands, Abdulaziz? I can't see.
I can't see more hands.
Then
To
I
be
can ask some
honest,
questions then.
yes,
Just
go ahead.
yes. So I'm just curious, Professor Booth. Those positive margins, in the Egyptian study, they gave adjuvant radiation electively for positive margins. They didn't include it. But in your study, BART study, the positive margins were randomized towards radiation versus no radiation. I know the numbers are small, but what happened to those people in the observation arm where they didn't receive radiation uh, for the positive margin?
In our trial,
Yes.
oh, there was only 4%. Handful were positive. I don't even know whether they went into the standard arm because there were hardly 4 or 5 patients. So our positive margin rates were very, very low. In the Egyptian trial, positive margin was not the only one that were taken. Even if they had negative margins, they were taken in the trial. Yeah. So I don't think we know what happens to positive margins.
Um, so, is there any rationale to omit the cystectomy bed in node positive patients? What do you think?
I would not. I would not. Given that now that we know it is relatively safe and you've seen that with your handful of patients, almost 25-30% will fail in the bed if you treat the nodes alone. So that is not going to be very nice. So I don't think it works. I initially in my in our ethics we had submitted that we'll not treat the bed, but then ethics said, why would you not treat the bed, show us the evidence. And then I had tried to argue with them. Then I also realized, let's treat the bed, this is the last chance. What's the point? So
And uh, just about this number of nodes dissected, if less than 10 were included in the BART trial.
no,
So,
no. Yeah. So that came from the UPenn data. UPenn data. We rarely had, I think one or two had less than 10 dissected. The UPenn data had that as a prognostic factor, but our median number of nodes dissected was 20. So that was not a case in our patients.
and do you think doing a PET scan, um, as a staging procedure will help to pick up this few lymph node metastasis
Post-op,
pre-op
do you
before
normally
as a
do a
staging
PET?
procedure?
Do you do a PET before surgery?
Sometimes when there is a doubt about the lymph node in a CT scan is showing 1 centimeter node, we are not sure. Uh,
We generally don't do that. If there's a doubtful node or radiologically it looks positive, we consider it as positive because there's a very high chance that it is going to be positive. In any case, they get neoadjuvant chemo now with some IO. So we wouldn't do a PET just for that. Sometimes what happens, there's a delay, multiple nodes are positive in the surgical specimen, and patients sometimes have a delay in recovery after surgery. Sometimes it's 2 months. At that time, we do a PET before going into adjuvant radiation just to make sure the disease has not relapsed somewhere else. Not before.
and what about you showed some subgroup analysis data, and the node positive are the one which got most of the benefit. How about PT3
Yeah, that got benefit as well.
and negative margins, node
Yeah.
negative? What do you think about this case? Because this comes in the tumor board, and I've been a bit reluctant to go ahead with these patients.
So T3, T4 also got a benefit. If it was T3 and N plus, also there was a benefit. So very difficult to tease out exactly who's getting the benefit. All the on the forest plot, all the dots, the things are to the left. So benefit is there in all the patients. It's just because the numbers are relatively small, you don't get statistically significant ones. But I would not, you know, I would not hesitate now in offering people who have T3 disease. It's not a good cancer.
Great. Any more questions, Abdulaziz?
I don't see any
There's one
questions.
hand.
I
Hassan.
think Hassan Misfer. Go ahead.
Yes. Yeah. Assalamu alaikum. Hassan Masfer Zahrani. I'm a urologist from King Faisal. Thank you for the invitation, Dr. Ridwanullah. I enjoyed actually the talk that brought me back almost 10 years ago when I was also treating bladder cancer. Now I'm mainly focusing on renal cancer. But this is an eye opener actually. Similar to what we had, the stories that, actually the good stories that we are sharing and having with renal cancer, with the radiotherapy. So I see a lot of opportunities here. The problem, I think, is we do not consider it now because we are not thinking too much of it. We have been using radiotherapy for bladder cancer as a palliation mainly, since chemo is there, whether it is the neoadjuvant or adjuvant. So I think having these data and hopefully the meta-analysis will show us more details on the good indications that we can offer radiotherapy. Yes, immunotherapy is a game changer, but I think it is not tolerated well by all the patients. So I think having, the radiotherapy in the back or in the mind of urologist and the tumor board members will add a benefit to some of our patients that we are discussing. So I will suggest we have like our tumor board being more and more consider these data, and hopefully the meta-analysis will show us more. But I personally enjoyed it, and I think it is an eye-opener. Thank you very much.
Wonderful, Dr. Hassan. I think my suggestion is you should come back to treat bladder cancers now.
I'm bombarded with renal cancer, but Dr. Rizwanullah is helping me a lot. I was calling him yesterday, actually.
We are a wonderful urology team in
Yeah.
King Faisal. And
I'm
all
sure.
the patients are discussed in the weekly tumor board.
Wonderful, wonderful.
Uh,
Wonderful. I
so
hope
yeah,
this will help. I hope this will help in your tumor boards. I surely, try a few, do a few more. Let me know if you need any help with any technicalities or anything else. Obviously, you're very experienced, so let me know if you have any ideas. If you want to maybe do a phase 2 study or something like that on your own, or let's keep the channels open.
Absolutely, I think
that will be
that's
great to collaborate with you guys. Absolutely, I totally agree. It's just we got a lot of residents now in Saudi Arabia, and very young consultants like Abdulaziz now
Yes.
joining us. So you have been doing sort of landmark practice changing clinical trials, and you showed today that took 10 years for you to almost from the start to the end. uh, do you have any tips for us? How you managed to do this kind of big studies, practice changing studies with limited resources? A lot of
Yeah,
young
well,
residents are there in
there's
the
a
audience.
lot. I will have to come there and talk. Is to many things are there. Many things are there. It's a whole ecosystem that you have to create. It didn't happen in one day, as they say. The Rome was not built in a day. It started with just starting to keep the database first. There were 10 patients of bladder preservation. Today, I just got it analyzed. We have 317 patients of bladder preservation over the last. So it's all about building it slowly. You have to start with your Excel sheet first, have a plan, keep going, and there's many things. So build an ecosystem, start something small like the immunotherapy, just 10 patients, 20 patients, publish it. It's a whole process. So it just takes two or three interested people to pull together the whole department. uh,
Right.
we Yeah, so start for all the residents. Even when you so when my residents leave training and go, they say, what should we do, how should we, I want to do research. I said, come on, research is not that easy. In 5 years, I'm going to ask you, you've treated 200 head and neck patients, do you know what has happened to them? Will you be able to tell me in 5 years your 200 head and neck cancers or glioblastomas, if they survived, have they not? How many got radionecrosis? How many got osteochondronecrosis? How many got grade 3? Will you know that? I mean, that is the first thing. You must know what you are doing. You must have an audit of every patient that you treat curatively, and that gives ideas. That starts the process. So without that, it's just going round and round circles, 50 grade to this, 70 grade to that, and go home and just relax. So that's where you must. That would be my first tip.
Thank you for these golden words. So if there is no more questions, Abdulaziz, any more?
I I don't think we have more questions, but we'll be honored, Professor, if we host you for our SARO meeting, which is done in Jeddah around the winter time. So Saudi Arabia is a little bit nicer to visit. It's the biggest coastal city that we have, and we'll be sharing with you the details. We'll be honored to host you, and also for you to share more wisdom. I think this is a very short time, but we
Yes.
would like to host you to
Yes.
talk more about clinical trials and collaboration. We have
I'd be
now this. Go ahead.
I'd be happy to speak to the residents about a little workshop of the practical tips about bladder cancer, prostate cancer. I've done it in many places, and it'll be a pleasure to connect with the youngsters. They're the
That will
future.
be great. Thank you so much, Professor. I think that we would be adjourning our meeting, and we are very thankful for you to share your wisdom with us. Thank you so much.
Thank you, all of you. Have a good evening.
Thank you, Professor Bhuti. Thank you very
Bye.
much. Hope to see you in person soon. Thank you. Have a nice evening, and enjoy the football match.
Yes, yes, tomorrow morning, yes, for us.
Thanks a lot.
Thank you.